Guys, some of you might know me from clinical, but my name is Taylor, and I'm going to be going through your fluid and electrolyte chapters with you. So the concepts of this chapter is, of course, fluid and electrolyte balance and how our body naturally maintains the proper balance that we need to function. We'll be talking about perfusion, abnormal values, homeostasis, and some other laws of fluid, basically, that the body uses to keep that homeostasis going. So homeostasis, of course, is just a broad term for the proper functioning of our body systems. Our body is composed of a lot of fluid. About 60% of it is total water fluid, and that is comprised of extracellular fluid, which is the plasma volume and the interstitial space. And then, of course, there's the intracellular fluid, which is the majority of body water. The interstitial space, which is part of the extracellular fluid, is the space that is between cells and outside the blood vessels. And then the transcellular fluids, which is also included in the ECF, is that of the epithelial lined spaces. So you can see the little graph down at the bottom that just kind of shows you the division of the extracellular fluid and the intracellular fluids. So filtration is the movement of fluid through cell or blood vessels because of differences in water pressure. So we have hydrostatic pressure, oncotic pressure, and those are different pressures that we'll talk about in some upcoming slides that basically just kind of help either keep fluid in the vascular space or outside of the vascular space. So hydrostatic pressure is the pushing pressure. It is the force that pushes water outwards from a confined space through that membrane. So the amount of water in any body fluid space determines that pressure. Blood pressure is one example of hydrostatic pressure. So moving whole blood from the heart to capillaries, where filtration occurs to exchange water, nutrients, and waste products between the blood and the tissues. So if you have a change in your normal hydrostatic pressure, that's how we develop edema. And edema basically is just an excess amount of fluid in those interstitial spaces. So if you have an increase in hydrostatic pressure, or that pressure that's trying to push out of the blood vessel, it's going to lead to that fluid shifting into the interstitial space. And that can be from a variety of reasons. Another reason could be the decreased oncotic pressure. And oncotic pressure is going to be your protein pressure, basically. So our body uses proteins like albumin, for instance, to keep the fluid inside the vascular space. So if you have a patient with liver failure, they're not producing enough of that albumin, you can see a lot of ascites. So lack of protein leads to a decreased oncotic pressure, which leads to fluid shifting into the interstitial space, which is another cause of edema. And you can see on the bottom left, there's some pitting edema, which is just another way to look for that extra fluid in the interstitial space. Pop quiz time. A nurse is caring for a patient who has a fluid volume imbalance related to the development of ascites. So selecting all that apply, what imbalance will the nurse monitor for? I'll give you the answer at the end of the PowerPoint, so just keep that in mind. Okay, so then we're going to go into diffusion. So diffusion is another way that fluid moves in the body. It's the free movement of particles or solute across a permeable membrane from an area of higher to lower concentration. It's important in transport of most electrolytes, and other particles diffuse through the cell membranes. So our body uses sodium pumps sometimes which is a way of using active transport to move sodium. We have sodium-potassium pumps, and these are just pumps that are on the plasma membrane that can help in the diffusion of fluid. And then glucose, for instance, which cannot enter most cell membranes without the help of insulin. So some parts of the body require other things like pumps or insulin to move certain fluids or electrolytes. And then osmosis and filtration. These act together at capillary membranes to maintain normal ECF and ICF volumes. So if your body is sensing a lower blood volume, you might trigger the thirst mechanism, which is an example of how osmosis helps maintain homeostasis. So if there's not enough water in the blood vessels, your brain's going to trigger a thirst mechanism, which is going to try to encourage you to drink water to further dilute your blood vessels and get some extra volume back in there that you might be missing. And again, the feeling of thirst is an activation of brain cells responding to changes in your osmolarity. And then fluid balance. So fluid balance is very closely linked to the sodium amount that's in the blood. So if your sodium is low, your water it's likely going to be low, and then vice versa. If it's high, it's going to be elevated. And this is also affected by fluid intake. So the more, of course, fluid that you drink, the more you're going to have in your body, and then the less, if someone's not drinking, they might become dehydrated. And this is extra important in someone that has maybe heart failure or kidney disease, that if they're taking in too much, they can develop an excess amount of fluids, which can lead to issues such as edema or electrolyte imbalance. So we have fluid loss, which can be monitored by urine output. So minimum urine output needed to excrete toxic waste products is about 400 to 600 mLs a day. So if they're not excreting that much, their body might be holding on to some of those electrolytes and waste products that could lead their body to become not in a homeostasis sort of state. And then of course you have your insensible water loss, which is through your skin, your lungs, and your stool. Hormonal regulation of fluid balance. So aldosterone is a major factor that helps to increase sodium retention. So if your body is not having enough fluid in it, if you're a little dehydrated, if you've lost too much fluid, your body can trigger the retention of sodium, which we know that if sodium remains, water will remain. So by retaining sodium, we can retain extra water to get our plasma volumes back up. And then we have antidiuretic hormone, which acts on the kidneys, the distal renal tubules, and the collecting ducts, which will increase water absorption into the blood. And this basically prohibits any water from leaving, or the excess water from leaving, and just allows our body to keep some water when we might be a little dehydrated. And then your natriuretic peptides help to maintain help to encourage sodium excretion. So if somebody is in heart failure, if they're retaining too much fluid, your body will try to naturally excrete some of that sodium, which will allow the water to follow. So this is the renin-angiotensin II pathway, which is another way that our body can maintain fluid volume. So plasma volume is the ECF, so the extracellular fluid, and ICF are most important to keep in balance. And our kidneys are a major regulator of the water and sodium balance. And of course, we need that to maintain perfusion to all of our tissues and our organs. So low sodium or water volume leads to kidneys secreting renin. Our bodies will then take renin and turn it into angiotensin I, which goes into angiotensin II, which can lead to the production and secretion of aldosterone, which again, like we talked about, will lead to increase in that fluid volume in our body. And this is it's greatly stimulated with shock or stress, is when our bodies can stimulate that extra renin and angiotensin II pathway. So then we have our ACE inhibitors, which can actually alter the renin-angiotensin system. So ACE is the angiotensin converting enzyme in the renin cycle. So when you go from angiotensin I to angiotensin II, you need to have this angiotensin converting enzyme. So we can give our patients the ACE inhibitors, which will actually decrease the amount of blood volume that our body is retaining. So in a patient who maybe has hypertension, they can take an ACE inhibitor and it will actually inhibit that renin-angiotensin pathway, and thereby decreasing blood pressure and fluid volume. So you'll get a greater excretion of water and sodium in the urine. So now we have dehydration. So of course, if you're not taking in enough fluid, your body can go into a state of dehydration. If a patient is vomiting, if they're not taking in enough fluid, or if it's maybe just extra hot outside, they're sweating a lot, they can lead to them being dehydrated a little bit. And if they are dehydrated, you might see some tachycardia, which is sometimes something that if someone's tachycardiac, we often don't always think that it might be just something from as simple as dehydration, but that can be a first symptom of dehydration. They might be tachypnic, so breathing fast. Their skin could be dry. They might have spells like fainting, and of course their urine could be concentrated. I actually remember I was at my sister's graduation when she graduated in like 2012, I think, and it was a super hot day. There was probably 1,000 people piled into this tight little area waiting to get inside, and I ended up passing out. It was extremely hot out that day, and I think I just got a little dehydrated and I fainted. So my body wasn't, there wasn't enough fluid to get all the oxygen to my brain, and it led to me passing out. So always want to stay nice and drinking lots of water if you're outside in the heat, because you don't want to be like me and pass out at your sister's graduation, because then you take all the excitement away from her. So just some facts to remember. A liter of water weighs about 2.2 pounds, which is equal to 1 kilogram. So weight change of 1 pound equals a fluid volume change of about 500 mLs. And again, if we're assessing our patient and their fluid volume status in our physical assessment, we're going to look for stuff like if they've been vomiting or had diarrhea, if they've been outside, look at their heart rate, their respirations, and their skin turgor, which will allow us to see if their skin is dry, if it tense, stuff like that. Patient safety, are they falling, are they passing out, do they have some hypotension, what drugs are they taking? Diuretics, of course, can cause dehydration, so we want to be careful with that. And then what are they taking in? Are they drinking enough? Are they eating enough? Or maybe if they have heart failure, are they eating or drinking too much sodium or not enough water? So always want to watch out for that sodium, because remember, where sodium goes, water goes. Dehydration as a result of excess fluid loss or inadequate fluid intake, which we talked about, and can lead to injury. If your blood pressure is low, you can faint. If your sodium is altered, if it's too low, it can lead to seizures and coma if very severe. Oops, sorry. So what are our nursing interventions? Of course, we want to restore the fluid balance. We want to give them fluid replacements. If their dehydration is really severe, we're going to go towards an IV fluid. If it's not so severe, we'll just give them something to drink. After I passed out at my sister's graduation, my doctor told me that I better start drinking up to like 3 liters of water a day, or some crazy amount. He said, or I'm going to put you in the hospital and give you some IV fluid. So he kind of threatened me a little bit and told me I needed to drink more, or I was going to end up on IV fluids in the hospital. And of course, we don't want that. So we always encourage our patients just to drink lots of water. Drug therapy, if they're dehydrated, again, look at their, are they taking any diuretics or any other meds that could cause them to be dehydrated. Teaching them to stand up slowly, monitoring their blood pressure for orthostatics, meaning that if they stand up, does their blood pressure drop? And giving them compression socks, which are just real tight socks that go on their, like pretty much from their foot all the way up to their knees, sometimes even higher, and keeps that blood flowing back up to the brain. Electrolyte imbalance can occur in healthy people as a result of changes in fluid intake and output. So excess salt intake, alcohol can lead to low sodium because they're diluting their body or their bloodstream, and injuries such as severe burns. And again, these electrolyte imbalances can be life-threatening if severe. So sodium normal is 136 to 145. Where sodium goes, water follows. If you're low, you can have seizures, muscle twitching, confusion, headache. And if you're elevated, thirst, seizures, confusion, and muscle twitching. So pretty similar, but there are some differences that you need to be aware of. Potassium's a big one with the heart. Normal level is about 3.5 to 5. So we're always wanting to look for our cardiac rhythms, EKG changes, stuff like that if our potassium's off. If potassium's low, you can get some U waves on your EKG, which might not make sense right now, but it will once you start learning about EKGs. Might have some heart palpitations, so some goofy beats. If someone ever feels like, oh my gosh, my heart just fluttered, well, maybe their potassium's a little low. And then elevated potassium, you're going to see some elevated T waves, and then again some cardiac abnormalities. Big one with this is muscle pain and cramps. And with hypokalemia, also muscle weakness. I actually just had a patient who her potassium was super, super, super low, and it got to the point where she was so weak she couldn't even walk. And they did all this testing, all this stuff, MRI, CTs, everything was normal, and just chalked it up to low potassium levels. So it's super important to maintain those potassium levels. Calcium's a big one with the bones and the muscles, so 9 to 10.5. You're going to need, of course, vitamin D to help absorb that the calcium. Calcium stored in bone. It's controlled by the parathyroid hormone. And so hypocalcemia, you're going to see a lot of muscular excitability, facial twitching, and then hypercalcemia, it's going to be muscle weakness. So So the top left picture is what we call the Trousseau sign. So it's a contractibility of the